So I'm Laurie Sehn from the BC Cancer Centre for Lymphoid Cancer, and I'm here at ASH. At this meeting, I presented data looking at the significance of a MYC rearrangement, either a single, double, or triple hit in patients with diffuse large B-cell lymphoma. This was a collaboration of the Lunenburg Lymphoma Biomarker Consortium. And what we did is we established a large cohort of patients of diffuse large B-cell lymphoma with contributions from population databases as well as clinical trials. Together, we amassed more than 2,400 patients with clinical information together with biomarker data. And what we identified is that the incidence of MYC rearrangement in this population was approximately 11%, in keeping with what's been reported. But importantly, we looked at the significance of MYC as to whether or not it was a single rearrangement or it was present as a double rearrangement with BCL2 or BCL6 or a triple hit. And what we identified was that having a single rearrangement of MYC was not a poor prognostic indicator for progression-free survival. However, having a double MYC rearrangement with either BCL2, BCL6, or a triple hit was a significant predictor for poor progression-free and overall survival. Importantly, there was no difference between the MYC BCL2 and the MYC BCL6 double hit cases. So, that was an important finding because that hasn't been clearly established before. And then finally, we actually looked at whether or not there was any implication of the MYC rearrangement partner. So MYC can be arranged with either an immunoglobulin or non-immunoglobulin partner. What we found was that of the double and triple hits, about half of them had a MYC immunoglobulin partner rearrangement and half had a non-IG immunoglobulin rearrangement. And it was only those patients that had the MYC combined translocated with an immunoglobulin partner that actually had the poorer outcome. So this has real clinical relevance because right now in many of our clinics, we're starting to manage patients with double and triple hit differently. But what we would realize is that half of those patients are actually standard risk patients. So it really is only the double and triple hit patients with the MYC IG translocation that have the poorer outcome. So I think that we all need to take that information home and to decide whether or not we need and can start testing this in our own patients, because we may be over-treating half of the patients with double and triple hit disease currently if we're not able to refine that testing.